May I request Dr. Soni to present the memento to the speaker, Dr. Vasant? And Dr. Rafiq to present the memento to Dr. Soni.
Thank you, Dr. Vasant and Soni, for being very much on time. We have the last session on where we have two parts by Dr. Jayaprakash, who is a consultant endocrinologist from Medical Trust Hospital. The first part would be a two-in-one solution suited for Indian realities. That's learnings from the Indian Cohort of ARISE study. And then the second part would be a case discussion, a patient with type 2 uncontrolled diabetes on multiple oral anti-diabetic agents. And our chairperson is Dr. Prasannakumar, who's a consultant physician from Sujintra Medical Center. Dr. Prasannakumar is a bit handicapped with this thing. Thank you. Thank you. Come. Over to Dr. Jayaprakash.
Yeah. Thank you, Rafiq sir. Respected seniors, my dear friends, let me begin by thanking API Kochi for giving me the opportunity. And I think the session was supposed to start at 8:55 and we are pretty late. I have been given 10 plus 10 minutes, 20 minutes. And taking the example, I am the last man batting. I am supposed to be the pinch hitter also. So this would be the agenda. I think most of these things are familiar. I will pause at certain points and brush through the other slides. The importance of achieving glycemic control, I need to elaborate to this audience. But this last line, which talks about the burden in terms of remaining uncontrolled for their diabetes control, the cost of care increases by around 32%. So yes, as the previous Dr. Deebu was telling, the cost of therapy has increased, but then the cost of remaining uncontrolled, actually the treating comorbidities and complications, that cost also has increased considerably. We know that among all the agents that we have discussed, undoubtedly insulin offers the maximum efficacy in terms of lowering blood glucose. From any level, it can lower to any low level. The data with respect to the dietary habits, on one side you have the pure study, Dr. Salim Yusuf, who is a relative of our Rafiq sir. He was the lead author, wherein they have looked at the effect of white rice consumption and insulin diabetes. As you see, the graph is much taller for India, Pakistan and Bangladesh, where white rice consumption is the most. Indian data from Dr. Shashank Joshi's group, also the START study, which have shown that carbohydrates form the 60 to 70% of glycemic load or the calorie load of Indian patients. And we know the effect of fasting and postprandial in terms of the blood glucose level. So this is 4 studies picked into one slide where the insulin initiation data has been shown. If you see from 8.5 to 9.2, 9.23, at every level, both the fasting and postprandial blood glucose are high when patients are initiated on insulin. And we know the guidelines, especially the Western guidelines, talk about basal insulin as initiator insulin, but as with respect to Asian patients, especially because of probably the high carbohydrate load, the glycemic response or lowering of blood glucose is actually lower with basal insulin compared to the premixed or co-formulation. So in our population, because of probably the dietary load, a premixed insulin performs better in terms of lowering. So with respect to the initiator insulin, the basal insulin doesn't offer a good control in patients who have a high carbohydrate load with respect to the postprandial blood glucose spikes, with respect to the delay in insulin therapy where we have fasting and postprandial both at the higher level as we have seen, and the convenience of total control in one insulin preparation. So these Indian realities, whether the innovation which we are talking about the co-formulation of idagasp, which I think has been there since almost 5 years now. It's a unique insulin. I think
of this
video illustrates this
is derived
well.
from its specially designed co-formulation of insulin degludec and insulin aspart. Insulin degludec is the first basal insulin that can be combined in a soluble solution with a mealtime insulin such that both insulin molecules remain structurally separate. In the Rhizodeg co-formulation, insulin degludec is present as soluble and stable dihexamers, each of which consists of 2 hexameric structures, made up of 6 individual insulin monomers within a single hexamer, while insulin aspart is present as single hexamers. Following subcutaneous injection, the additives disperse and the insulin degludec dihexamers assemble to form soluble and stable multihexamers, creating a depot of insulin in the subcutaneous tissue. And the rapid-acting insulin aspart hexamers promptly dissociate into individual insulin aspart monomers, which rapidly enter the bloodstream and are delivered to primary target tissues such as fat and muscle. The insulin aspart monomers bind to and activate insulin receptors, promoting rapid insulin action. In parallel, at the site of subcutaneous injection, individual insulin degludec monomers gradually separate from the ends of the multihexamers and slowly and continuously exit the subcutaneous depot into the circulation. In the bloodstream, the insulin degludec monomers bound strongly but reversibly to albumin. In primary target tissues, insulin degludec monomers bind to and activate insulin receptors, triggering cellular changes that promote glucose uptake and utilization.
So that's why the distinct mechanism of action where you have the aspart acting at the postprandial agent and then the delayed action of degludec gives the basal coverage. So as an initiator insulin, this is the Onishi study in Japan where they have found that compared to glargine, the A1C reduction is better by 1.4% and similar postprandial fasting and reduction with this. Especially the postprandial blood glucose control over the post-lunch period is better with idagasp compared to insulin glargine. So the importance of postprandial control, Dr. Vasant had already discussed, wherein how it can affect the multiple complication pathways. So the patients remaining in target or reaching target, idagasp had 72% improvement. Higher time in range is a concept that we have now evolved in terms of measuring the overall glycemic control. So the time in range with reduction in time below and time above range was also better with idagasp compared to glargine. The RSSDI ESI guidelines were the convenience of initiating an insulin at once daily and then increasing optimizing the intensification with the same preparation is there, which can be easily done with idagasp or co-formulation. Now the ARISE study, which again is a real world study where considerable number of patients were involved from India also. It's a study where idagasp was initiated at various levels, various countries, where the physician decision was to start either as once daily or twice daily, and it showed that the improvement in glycemic control compared to other insulins was better with idagasp. The Indian cohort, actually 185 patients, were the decision in terms of the physician to decide on whether to start idagasp. The primary decision was to improve glycemic control. Other convenience and less number of injections were also important in decision making. So equal number of physicians prescribed it as once daily, almost 43%, or 56% prescribed it as twice daily. So this is the practice prevalence. We can use it as a once daily or a twice daily preparation. The change in baseline or improvement in glycemic control compared to global and Indian cohort. Indian cohort performed slightly better, 1.6% reduction. Whatever be the prior therapy these patients on, whether they were oral agents, basal or GLP-1 receptor agonists, or patients on basal bolus therapy, all these patients had significant reduction when they were switched to iodagasp. So the fasting blood glucose reduction was significant, 190 milligram per deciliter, and the importance is here where hypoglycemia episodes were counted. So if you see non-severe and severe hypoglycemic episode were lower with iodagasp, the Indian cohort actually performed better, even though the numbers were small, but significantly lower amount of hypoglycemia was observed in the Indian cohort, and the cost and or the resource utilization in terms of patient visit to emergency, patient visit to as an emergency visit, not a planned visit to casualty or OPD because of the complications of hypoglycemia. The cost involved in that they had calculated, and it was found that 90% reduction was seen in the missing of their work day and 61% reduction in outpatient visit. So less of cost involved in terms of the indirect cost of hospital visits and other things were seen. So significant lowering, significant reduction, both fasting and HbA1c, lower hypoglycemic events and lower resource utilization was seen. So practical recommendation, I'm sure you would have all used this insulin. The recommendation is to start once daily along with the major meal and titrate it plus or minus 2 units according to the target, 5 days to 1 week. So the different pen preparations which are available, and if you can see now, one more important aspect is the Ramadan which is coming up, and there is data with iodagasp which they have compared with the premixed insulin, which has shown that patients on iodagasp had similar HbA1c level achieved with lower amount of hypoglycemia and lower amount of nocturnal hypoglycemia, 74% and 83% lowering compared to premixed insulin. So this is significant as in another, I think, a week, Ramadan is approaching. So similar glycemic control, lower amount of hypoglycemia, and with one single injection you achieve the total control. I think that is the end of the first part.
I think we will have the question answer session after the second part.
Yeah. So I'll finish this in 5 minutes, a simple illustration. So this is a case, a typical patient that we see in our outpatient, multiple OIDs, uncontrolled. 56-year-old school teacher. He's on gliclazide 60 milligram, linagliptin 5 milligram, metformin 850 milligram twice daily. So 3 oral antidiabetic agents in pretty good dose, and other agents. So this was his A1C 9.5, fasting was 220 and postprandial 312, A1C of 9.5 when it was decided that he should be on insulin. This is again, most of patients agree to this when they reach this point only. So he was initiated on once daily iodagasp, and the gliclazide was discontinued. Whenever you have a prandial insulin on board, it's better to discontinue sulfonylurea. And it was introduced at the time of major meal. Major meal, most working situations is the dinner where you have a family meal, and that was started. And at 3 months, his A1C started improving, and at 6 months, he had reached around 7.9, and at around 8 months, it was 7.3. 6.9 was reached around 9 months. So this is the typical profile that we see when the patient is initiated on insulin, and you titrate it accordingly when you reach the target. And a CGM was done, and this shows the AGP profile where you find the time in range is maximal seen in this patient. So aim for total control with reduction in hypoglycemia, and better overall control was seen. Thank you.
Thank you, Dr. Jayaprakash, for the excellent presentation. Now the case is open for discussion. Please, questions can be asked. Questions from the floor.
So, as per your presentation, this albumin is having a role in stabilizing the degludec blood. So, is there any possibility that patients who are having hypoalbuminemia, a chance of hypoglycemia with degludec?
No, it has been studied in patients with degludec has been studied as a basal insulin in patients with CKD, in patients with chronic liver disease, where hypoalbuminemia is known to occur and it has not been found to have any kind of extended duration or increased risk of hypoglycemia in these situations. Actually, the stabilization in terms of the release of the molecule is in the subcutaneous plane. And in the bound form, with respect to the binding to the albumin, is only a minimal amount which kind of dissociates from the albumin and binds to the insulin receptor. So it doesn't significantly affect in these patients.
Any more questions? What about this Rhizodec? Renal safeties, everything is really good.
Yes, both degludec and aspart is known to have proven efficacy and safety in patients with renal failure and hepatic failure. Actually, the advantage of less hypoglycemia with both these agents, degludec and aspart, is kind of one of the advantages which is to be used in patients with organ failure. So, Rhizodec being the combination of both, it has the benefit of both these agents with less hypoglycemia, and the prandial component gives the postprandial improvement also.
Comments from this.
I think we are towards the end. I'd like to just see a few comments just on short thing. All speakers have done extremely well. So Dr. Ramoshan's talk was very interesting. I would just like to comment that regarding the insulin resistance by the patients, we can break that down by having good counselors. Everybody should have some good counselors, or other nursing staff should be trained to counsel the patient, and they can do much better than us, because we don't have the time to sit back and talk to them. We can just suggest, but the other person will be able to make a much better impression on them. Regarding Dr. Deepu's, somebody was asking about the HbA1c. A1c at present is slowly going out of limelight, and the newer terminology, time in range, is coming. So that is more important now, and we are stressing more on that. And in fact, everyone do not in fact have to have a continuous glucose monitor itself. Now the newer glucometers are coming with Bluetooth connectivity to your phone itself. So once you start doing it frequently, you can get a time in range graph on your phone itself. So that will be it'll be much easier than having a expensive device connected onto you. So these are all these. I think with a few, in a couple of years' time, time and range by the CGM also will be going out of, the HbA1c also may be slowly be eased out from the system. Dr. Vasant did a very well informative talk on postprandial hyperglycemia regarding the complications which we have. And of course, Jayan, due to lack of time, but he really did well. He explained the whole the studies which are coming up, and has enlightened us about the importance of using Rhizodec, which is quite an effective, one of the most effective insulins at present available. I thank IMA and also Novo Nordisk to having invited me and given me this chair. Thank you. Closing the session. Over to you.
I request Dr. Prasannan sir to hand over the memento to the speaker, Dr. Jayaprakash. And Dr. Rafiq sir to present the memento to Dr. Prasannan. I request Chairman API Dr. Radhakrishnan to present the memento to Dr. Rafiq Mohammed. May I now request the returning officer, Mr. Dr. Madhu Kumar, to announce the results of the election.
Good evening, everybody. Today, I am interested with the job of returning officer for electing the new office bearers of APA Kochi for 2022-23. And accordingly, nominations were accepted, and the nominations were for the chairman, vice chairman, secretary, and treasurer. And for the post of chairman, only one nomination has come, Dr. Abraham P. George. And for the post of vice chairman, Dr. Prasannakumar. And for the post of secretary, Dr. Sumesh Chako. And finally, for the post of treasurer, Dr. Sheetal Binu. And four of you, if you can come to the stage. All four are elected as there are no other contestants for the post. And finally, we had a very good one-year session from the current office bearers, and it was very, very good, and it is fantastic also. And I hope the next team will fare better, and I am giving all the best for all of you. Thank you.
Thank you everybody for choosing us. This is not a new team. Actually, the all team, except for me, and Dr. Sumesh as the secretary, and Dr. Sheetal as the treasurer, and Dr. Prasannan as the vice chairman. These are all new, all faces. I am the only new one. Hope we'll do better than the other team. Thank you.
I thank upon for our colleagues that again they have entrusted me for the next 1 year to conduct this organization in a better way. I hope I can do better in this. Thank you very much.
I would like to thank the APA fraternity for nominating me again to the APA organizing committee, this time in a bigger and more responsible position of the secretary. As you can see, the team has been changed slightly with minor cosmetic changes. So our team, we request the wholehearted cooperation and support from all of you present here for smooth conduction of the various activities of API. Thank you.
I have been entrusted with the post of treasurer, and I hope I will perform well with all your support. Thank you.
Now I ask non-noticed people to say a few words.
Thank you very much, APA Kochi, for giving us this opportunity. I know I am just standing between the dinner and all of you, so I won't take too much of time. Once again, thank you very much, APA and the entire speakers and chairperson and moderator Rafiq sir for making this program very successful. And we have a very strong team here in Kochi. They really made this program with their all-utter support. So for anything regarding insulin, we are always there in the front run. Please feel free and contact us. We will take care of entire aspect of that. Thank you very much once again. Thanks a lot.
Good evening, ladies and gentlemen. On behalf of API Kochi, let me start by thanking the participants of today's scientific program the Improve Conclave, that is improving patient control with real world evidence. The speakers, Dr. Ramakrishnan, Dr. Deepu George, Dr. Vasant PK and Dr. Jayaprakash together have eloquently explained to us how to tailor the treatment of diabetes along with the oral hypoglycemic agent and insulin in accordance with the patient's requirement. Also, the management of postprandial hypoglycemia, uncontrolled diabetes and psychological insulin resistance were explicitly discussed. All the chairpersons, Dr. Shamala Menon, Dr. Paul Puthuran, Dr. Soni Joseph and Dr. Prasannakumar, each one of them with vast experience in clinical field, have shared their pearls of wisdom with us. I thank them for educating us. It will surely help us to deliver enhanced quality care to our diabetic patients. I would like to thank the moderator, Dr. Rafiq Mohammed, for having moderated the session brilliantly. I would like to thank Dr. Madhukumar for having diligently conducted his role of the returning officer in the election process for the next API committee meeting. Hearty congratulations to the newly elected members of the Executive Committee of the API Cochin 2022-23. I thank Novo Nordisk for having graciously sponsored the scientific program and also helping us to organize it. I thank IMA managers Mr. Sandeep and Mr. Jijo for all the impeccable arrangements made in the IMA hall today. I thank the audiovisual team led by Mr. Arun Moses and Mr. Renish for the technical support provided. Next, let me thank my committee members, Chairman Dr. A.P. Radhakrishnan, Vice Chairman Dr. Prasannakumar and Treasurer and Dr. Sumesh Chako for their absolute dedication to the proceedings in the committee. Last but not the least, let me wholeheartedly extend my gratitude on behalf of the committee to each and every one of you for having attended today's meeting despite your hectic schedule. Thank you once again.